Okay, welcome to your diabetes lecture. I've also included in this PowerPoint presentation the skills of using the glucometer to get a finger glucose reading from a patient, as well as calculations for insulin drips, and everything that applies to your skills and doses calculations for Module 4, Exam 4. So first, there's a little background here on diabetes and diabetes mellitus and diabetic ketoacidosis, which is when diabetes is severely out of control, the glucose is super high. You can view this video on your own time. It is a little lengthy. I don't want to waste my presentation time for this. So this just gives a little bit of background. It will not be tested over in my class, but maybe help you understand the process of what we're treating with these medications. But in general, diabetes, you usually have hyperglycemia. There are instances of hypoglycemia, so low blood sugar, and so there are some medications to help with that. But for the most part, we are treating high blood sugar. So in normal situations, that stimulates the pancreas to release insulin and transports insulin into the cell, which then decreases the blood sugar. That's the normal regulation. But in diabetes, there's a deficiency in insulin and or cellular resistance to that insulin crossing into the cell. And so then we need medications to help either make it cross or giving insulin directly to them to decrease those glucose levels. So again, you can view this presentation that I found on diabetes and DKA on your own time. I recommend it. Okay, so this next video here is about using the glucometer. I've spelled out the steps here for you. You first need to, of course, use hand sanitizer, wash your hands, apply your gloves. You first scan the provider that's doing it. On your badge. You would have a little barcode, then the bottle of strips, and then the patient. You need to make sure that your strips are not out of date. They only last for a certain time frame. When we go to the facilities, they have, when you get your little barcodes later, you'll have a little test that will fill out that I think it's 3 months that the strips are good for 1 month, and the what's it called? The controls are good for 3 months. So once that bottle of strips has been opened, you have to write the open date and then the 30-day expiration date on it. So you do need to make sure that they are not expired. If they're exposed to too much air or moisture in the air, can alter the strip readings, is why. So once you scan all of that, then you insert the little strip with the barcode into the glucometer, apply alcohol pad to the fingers of the patient that you've chosen, allow it to air dry, of course. Then you use the lancet device to poke a little hole in their finger. You squeeze, kind of milk it out, and you wipe away the first drop with your gauze. And then you squeeze for a second drop, and the second drop is the one that you use for the glucometer. The first drop might be altered because of alcohol that's still on the area, might be altered because of the superficial blood isn't like a good reading. So the second one, you're getting more of the central blood and has a better reading on that glucose result. All right, so once you get the second drop on there, then you apply gauze to the side, of course. You can ask them to hold it. You put the strip of the glucometer against the blood, and it sucks it up into the strip. Make sure that that glucometer stays level. You don't want the blood going into the glucometer if you raise it up. So as soon as you get that blood in that strip, then just set it on a table. So placing it level and waiting for the result. Then you can apply the bandage if necessary, if it's still bleeding. Once you it beeps. It lets you know what result their glucose is, and you can remove the strip, place the strip and the lancet in the sharps because those are contaminated with blood, and then throw away your gauze, your gloves and everything in the trash, hand sanitizer, and then you record the reading. Depending on what the reading is, you might have to notify the primary nurse if you are not the primary nurse at that time, but for clinical whatever or CNAs, they are to report it to the nurse. If it's below 70, it's considered low and we need to intervene. And if it's above 150, usually that means that they're going to probably get some insulin. All right, so the first line of treating diabetes is of course going to be diet and exercise first. Then in the event that those are not controlling the hyperglycemic episodes, then we will start with oral hypoglycemics. So these are like the glipizide and metformin. These are the main 4 that I have ever seen. Usually it's glipizide and metformin. So these act in different ways. So this is just a summary of all the different ways that they act to help bring that glucose level down. So promotes or increases insulin from the pancreas, increases glucose uptake, reduces the production of glucose, increases the response to insulin, slows the carbohydrate absorption, or excretes glucose through the urine. So there's different ways that each one of these medicines work. But with concern, of course, with hypoglycemics, so they have a high blood sugar, we give them a hypoglycemic, and so the intent is to drop their blood sugar. But if it drops it too much, we are also obviously going to be concerned about that. So we want to watch for hypoglycemia in any of these, and then especially in insulin because it does drop it faster. But specifically glipizide also can cause weight gain, whereas metformin has GI effects but weight loss. Okay, so there's a difference there. Can also cause B12 and folic acid deficiency and lactic acidosis on just the way it interacts in the chemistry portion of it. Sitagliptin is usually more well tolerated, but if there's any kind of issue going on, it's going to be pancreatitis that we should look out for. So considerations as a nurse administering an oral hypoglycemic, we need to consider that if they have any renal, liver, or heart failure, then they may not be a great candidate for this. These are not used in the treatment of diabetic ketoacidosis. Remember, that is the severely high blood glucose, so we will need to treat that very carefully. We will not go over that really in our class. When we get to DKA and your other med search classes, health and illness classes, you'll get more there. But specifically, just know in general, DKA, we are not treating DKA with oral hypoglycemics. Okay. These should be taken on an empty stomach. When you look through on your book, they all pretty much say the same thing except for metformin. It says to take with meals. So like at the time of meal. And of course, exercise and diet should be continued through this. This is not a substitution for their exercise and diet regimen. This is in the event that it is not enough. So it is to supplement, not replace their exercise routine. All right, so then we move on to insulin. So in the event that diet and exercise are not working for the patient, and then also oral hypoglycemics are not controlling their diabetes, we can resort to insulins to better control their hyperglycemic episodes. They can also jump directly to insulins in the event of severe renal or liver disease, as those were concerns on your oral hypoglycemics, remember? So they may not be a good choice for them to have the oral hypoglycemics and may just jump to insulin. Or if they're having painful neuropathy, so that's on their fingers and their toes, they can have peripheral neuropathy. If it's progressed and very painful for them, despite their glucose being managed, and they're having these symptoms. They can swap them to insulin to better control that pain associated with their diabetes. If they're undergoing surgery or diagnostic tests, sometimes we can give them insulin in order to help with the diagnostic tests that they're going for. We'll get into that in later semesters. During severe stressful situations like trauma or infection, your glucose jumps up. So even though they were previously managed on diet, exercise, or oral, they might need insulin in the short term until this stressful period of time, like their infection, has been managed more appropriately. Then their glucose levels can be more managed, and they might be able to come back off of the insulin. These are also used in the emergency treatment of DKA, so diabetic ketoacidosis. So they have the ketones in their urine and they have acidosis. And then hyperosmolar hyperglycemic non-ketotic syndrome, so they do not have ketones. They do have some acidosis, but not as much. So these are both events, emergency events that need to be managed very carefully and slowly, bringing down their high glucose levels. We'll get into a little bit of that later. But remember, the oral hypoglycemics are not used to treat these emergency situations. Also with insulin, when we use insulin helps transport the everything into the cell. So everything, it also will follow the potassium, or potassium will follow it. So potassium from the vasculature will then transfer into the cell. So then your vascular potassium levels are going to drop. So we can use this to treat hyperkalemia, but we'll also see this as a concern about dropping the potassium not on purpose. So that's one of the concerns we'll look at later. So dealing with insulins, there's multiple types, but they're going to fall into pretty much these 4 categories of rapid, short, intermediate, and long acting. Your rapid acting are going to be your Lispro, Aspart, glucosine, and inhaled human insulin. Your short acting are going to be your regular insulin. These ones you'll see more on your AC, your before meals, or might be on your sliding scales. Your intermediate are going to be your NPH and Detamir, which are going to be more of those ones that they'll take once in the evening or twice a day. And then your long-acting insulin are going to be your Glargine and Degludec, which I've not ever seen that one. But in high doses, Detamir can be considered long-acting as well. So these, again, will be that once a day or maybe twice a day. Okay, so this is a little chart I made for you to kind of put it all together so you can look at it and look at it and look at it and continue to try to memorize this chart. So you'll see that with rapid acting, their onset is much quicker. So rapid acting, of course, so 15 to 30 minutes. You're going to peak at 30 minutes to 2.5 hours, and then your duration is going to be 3 to 6 hours. Okay, so these are not going to act for very long, but they're going to act faster. Your short acting is going to be a half hour to 1 hour, and peak in 1 to 5 hours, and then your duration is 6 to 10 hours. These ones are the ones that you'll see more often as the AC, so before meals, and that's why we give them with meal times, because by the time it's acting, we need that that meal to be in the person's stomach to cover everything. So that's why that 30 minutes to an hour, so we don't give it this type of insulin, rapid or short acting, until the food trays are on the floor. The peak and the duration time you'll see, so the peak is 1 to 5 hours. That's why we'll give it again at the next meal to cover and keep covering. These ones might be on that sliding scale as well, so they may get more at one time and then another time, and just be based on the patient's needs. Okay, the intermediate acting, you're going to be 1 to 2 hours of onset. You're going to peak 6 to 14, and duration is going to be 16 to 24. So these ones they might get once a day or twice a day to kind of balance out those short acting during the meals. And then your long actings are going to be an onset in about 70 minutes. They have no peak time, and then they're going to last 18 to 24 hours. So these might be those once or twice a day medicines as well. Okay. Okay, so insulin injection sites. So we've kind of already gone over this a little bit. So this goes more into the skills of it. So these are your available sites on the picture on the top side. Of course, site A is our most preferred because it is the most fatty, most easy to get to in the facilities, and easy for patients to get to. Patients, when they go home, they might choose to do their outer leg if they have a lot of fat tissue there, because it might be easier to do it there, especially during the summer, so that they can go to the beach and not see their little prick marks. But in general, we will be giving it in the abdomen. So you're going to rotate those sites. We are giving it subcutaneous, remember, but we're going to rotate those sites to those 4 quadrants, and there's actually 4 quadrants inside of each site. So you'll see on the bottom picture there. So you want to ensure that you have the proper needle length and syringe type. So an insulin syringe, and use it to verify that the injection is going to the subcutaneous layer and not intradermal, which is too shallow, or intramuscular, which is too deep, right? So that's why we would pinch up and give it at that 45-degree angle to make sure it goes into that subcutaneous layer. All right, storing insulin. Insulin is kind of weird. So unopened vials of insulin can be stored in the refrigerator until their expiration date. So they can last a pretty long time. But pre-mixed insulins, we'll get into those shortly, they need to be stored, they can only be stored for 3 months in the fridge. Pre-mixed insulin syringes, so they've already been mixed up and they have the syringe on the tip. They can only be stored for 1 to 2 weeks, but if you're storing them in the fridge, they have to be needle up. I've never seen these available. Usually, if you're going to mix your insulin, you're going to do it yourself. But if you do have a facility that premixes these for you, make sure that they're being stored with their needle up, so that it's not separating and getting stuck in the tip of the needle end where you can't really mix that back out. So then you would need to mix it and by gently rolling it and rotating it in your hands. This warms it up a little bit as well as mixes it, but you should not shake it. In-use vials, so sometimes these are, usually they are always multi-use vials. So these in-use vials can be stored at room temperature as long as they avoid the sunlight and the heat, but they should be discarded after 1 month. Usually in the hospital, we're going through that in a matter of a day or so, but at home, it's important for the patients to know to not keep it longer than a month once it's been opened, making sure that they clean the top each time that they use it. In the hospital, we will still see these being stored in the refrigerator, not at room temperature. That's just a little tidbit. I'm not really sure the reason why. Probably to maintain that it's being properly used, because it comes out and in and out and in and out and in all throughout the day, just to make sure it doesn't get into a warm space. But that's just my theory. But you'll see these still in a refrigerator in the facilities. But at home, they can store it at room temperature if they choose. I know a lot of diabetic patients that I know still store it in their fridge as well. And their syringes, their empty syringes for some reason. Just so it's all together, I guess. All right, there is the ability to administer inhaled insulin, so like through like an inhaler. So they're dry powder cartridges. They are available in 4, 8, and 12 unit cartridges. So then they may need multiple cartridges in order to fulfill their insulin dose. So this is another education piece. So if they need 16 units of insulin, they don't just do the one cartridge. They need to pay attention to which cartridge they're using, which ones they have, and how many cartridges that they will need to be using. Okay, to make sure that they get the full 16 units of insulin that they're supposed to be getting. All right, now progressing to IV insulin. So this is when it are serious issues going on. There's a very high glucose, and we need to get that rapidly decreased. They will be monitored in an inpatient facility when you do this. So this is not like being given at home or in the emergency EMT truck. This is, they might be given it and then coming into the hospital, but they're not going to just give it and then leave them at home. Typically, IV insulin is going to be regular insulin, diluted in normal saline and given as an IV push. The only other ones that can be given IV are aspart, glucosine, and lispro. We'll get to on another slide about certain ones that cannot be mixed or given IV. But those are the only ones that are available as an IV. When you're done, if you're administering it not directly to the IV site, if you're administering it through the tubing, it sticks to the tubing. And so then in that case, you would need to flush with 50 milliliters of whatever solution that you're giving them, because the insulin sticks to the tubing, and make sure that they get all the insulin that they're supposed to. But in most cases, we're just giving it in a little syringe directly to their IV and then flushing really good afterwards, to make sure that nothing gets stuck in that little site instead of having to worry about it being stuck in such a long tubing. But it sticks. All right, pre-mix insulin. So this is when we're mixing different onset of actions type of insulins into one syringe. These ones are already pre-mixed in the vial, so that's why it's important on that one worksheet that we were talking about. Some people just put NPH. Well, we need to know what percentage. So it's 70% NPH. So then that's 30% regular. So that's the mixture of intermediate and short acting. So it's important to know the percentage of mixture, so that for documentation, because there are different mixtures available. Your book only mentions these two. There are other ones though. And then the other one it mentions is the 75 of lispro protamine and 25 of plain lispro. So that's an intermediate and a rapid acting. So it's going to be having both of those onset, duration, peak, different times, and then all in one syringe. Now we will move to mixing our own insulin. So if it's not already pre-mixed in your vial, we can mix them ourselves, but there's a lot of precautions here. So when we try to mix different types of insulins, we need to make sure that we go from clear to cloudy. So your clear ones are going to be your short and rapid acting ones. You need to roll the vial in your hands just like before. So you're mixing it up. You do not shake the vial. You inject your air into the regular insulin first, and then pull out your amount that you want of the regular insulin, and then tip up and pull back the air amount that you want for your cloudy, so usually your NPH insulin, and then put it into your NPH vial and inject the air, then pull back the amount that you want so that you know you have the total amount of how many units of insulin that you need. And then when you come out of the vial, you should have a total. So if you needed 3 units of regular and 2 units of NPH, then your syringe should read 5 units. So a little addition there, but that is one of the calculations that you'll need to know about how to add it in your syringe, and also knowing the order in order to do it. So you always do the clear, so the rapid or the short acting first, are usually the clear ones. The longer acting insulins are usually the cloudy versions, okay? So here's where it is mentioned about glargine and detamir cannot be mixed with other insulins and cannot be administered IV. Okay, those are your 2 exceptions. You should know those 2 exceptions. Okay. This is another video about doing that whole process that I just described, again, that you can watch on your own time. Some more insulin calculations. So we can do it on a sliding scale or per weight. So sliding scale are usually, again, those short or rapid acting, usually short ones, that they will be on a sliding scale. So they're using their blood glucose to determine how many insulin units to be administered. So one example of this would be that their order is for 250 minus their blood glucose, and then divide that by 30, and that equals how many units of insulin that they are to receive. So if their blood glucose was 200, so then we would plug it in and be 250 minus 200 equals 50. 50 divided by 30 is 1 2/3, so 1.666. So then you would round up to 2 units. Okay, so we would, depending on the facility, some facilities want you to do half, round to the nearest 0.5, but in our case, we're going to do most likely to the nearest whole number. So you would give 2 units of insulin for that patient in that instance that they got a 200 blood sugar finger stick. Okay, so insulin can be combined and added to other orders to limit injections to the client. So say this client had an order for 1 insulin and then also the sliding scale, we can mix those together. Sometimes that order is the same, so regular insulin. So if they have a scheduled every meal insulin of 3 units plus a sliding scale of this calculation, so then they needed 2. So then we could give 3 and 2 units, so then total of 5 units of regular insulin before their meal. So they may have duplicate orders or insulins that can be mixed together as per the last slide, so that we're limiting how many times we're injecting them, because they are being injected before each meal and sometimes before bedtime, and some people even before in the morning at like 3 a.m. So they're already being injected so many times. That's why you rotate all 4 quadrants and then 4 quadrants in each quadrant. So if we can limit and try to only inject them once per time, the better. But again, remember those 2 exceptions that cannot be mixed. Now, other insulin calculations are going to be per weight. So this is kind of like that heparin. So an example would be like Detamir, those longer acting medications. It's going to be weight based. And so you'll see like 0.4 units per kilogram. So then you take your kilograms times the 0.4, and then you get how many units that they'd get on that one time or twice a day. And again, remember, Detamir cannot be mixed. So your long acting cannot be mixed with your sliding scale short acting. They will unfortunately have to get those separately. Okay, the last set of calculations included in this section are going to be your insulin drip calculations. So here's an example of an insulin drip protocol that I separated into 2 pieces so that you can see where it kind of starts. So this is a patient that has an insulin drip going continuously. It's going at whatever rate that will be given to you in your question for your exam. And then I will give you this image, and then I will tell you that for maintenance, the picture on the right, so it was already going at this rate. Now the patient's blood sugar is 122, so that falls in that category of 111 to 140, and the action tells us to decrease it by 1 unit. So then you would subtract 1 unit from the rate of units that I gave you initially, and that would be your new answer. So you would have to apply this. I will give you the picture each time for the question, and then the portion on the left side tells you about the initiating an insulin drip. So there's the how much bolus and what to start the infusion rate at. So that's just rating the order. The for the protocol. So you don't have to memorize these because I will give them to you, but make sure that you read the questions carefully so that you know where you're looking at, okay? Insulin concerns. So, of course, they are hypoglycemic agents. They act rather fast compared to the oral hypoglycemics. So, we're going to monitor for hypoglycemia. So, this is when their glucose level is less than 70. So, when they take their finger stick or they have their morning lab draws and it's below 70, they are considered hypoglycemic, whether or not they're having symptoms or not. We'll talk about asymptomatic versus symptomatic treatment of diabetes in your health and illness classes, but in general, we'll just talk about hypoglycemia in general and then how to treat it in general. So hypoglycemia usually can result from too much insulin, or we gave the correct amount of insulin for them, but they decided they weren't hungry, so then they didn't eat like they were supposed to. Or that they have vomiting and diarrhea, so they've lost those carbohydrates. Alcohol, exercise, and childbirth are stressors on the system, and so they can actually overuse the insulin reaction to this can be overproduced, and so they can drop their blood sugar that way. So symptoms of hypoglycemia are going to be tachycardia, palpitations, diaphoresis, shakiness, headache, tremors, weakness, lethargy, and disorientation. So it's very stressful to their system. Sometimes they can start feeling like an aura before it happens, and they can start taking their snacks. So we're going to treat this if they're conscious with 15 grams of a snack. So that can be, your book describes 4 ounces of orange juice, 2 ounces of grape juice, 8 ounces of milk, or glucose tablets for 15 grams. You don't need to know how many ounces of each kind of thing. That'll be an option for you to pick one of those. I'm not going to ask you to memorize 4 ounces of juice versus 8 ounces of this other juice. So just know that those are options. Of what kind of juices are options. We don't really like to do apple juice, and we don't like to do sodas. So those don't last very long, or will keep the carbs in them will make the glucose last longer. And so then you'll end up with a hyperglycemic episode. So make sure that you know that these are your options for a conscious patient. Now, in an unconscious patient, unconscious patient, then of course we don't want to shove things in their mouth and risk aspiration, so we're going to inject it parenterally. So usually IV, that's why that one's bolded. So usually we can give IV because they're already in the hospital. But if they don't have an IV or their IV is not patent when we go to try to use it, we can administer IM or sub-Q. But of course, those ones take a longer onset of action, and if it is in a severe crisis moment, we're going to try and give it IV as best as possible to decrease all of these symptoms. So if they are unconscious, of course, we are at the very end. Your brain definitely needs glucose to continue operating, so your brain is going to start shutting down. That's where most of these symptoms come from. So paying attention to their level of consciousness is going to be one of the main keys for monitoring for hypoglycemia. Okay. Now, education for the patients, they should wear a medical alert bracelet just in case this happens out in the public, so people know why that they've suddenly collapsed, or have a snack and glucose handy because they might have that aura sensation and they just go ahead and take it and prevent that collapse. Now, another concern for insulin is hypokalemia. As previously discussed, it pulls that insulin that potassium as well. So we can give this actually to decrease their potassium levels. Now, if the potassium was normal and we have to give them a bunch of insulin, now we might be concerned about hypokalemia. So we're looking for muscle cramping and cardiac dysrhythmias, of course. Another concern about insulin is the infected fat tissue, so that's called hypertrophy, and that is spelled wrong on your slide. I just realized that. Hypertrophy, so like inflamed. So that is why we rotate our sites within at least 1 inch of each other between each previous injection, so that we are trying to prevent this infected and inflamed response to any kind of puncture site. Even though it's a tiny insulin needle, there is some sort of inflammatory response to it. And if we are doing it right near each other, it's going to continue to be inflamed, and that can lead to infection. So that is why we rotate that. Okay, so hyperglycemic agents, so these are used in the emergency management of hypoglycemic episodes when oral or IV glucose is not an option. So remember, on the previous slide we talked about hypoglycemia and how to treat it for conscious and unconscious patients. So if you are unable to give those glucose tablets or give it IV or IM, we can give glucagon. Glucagon is usually given IM. It can be given IV or sub-Q. I've usually seen it as IM option. This can cause some nausea, vomiting, and it's usually pretty rapid once the onset of glucagon starts happening. So it's very overwhelming to the system when they went from a very low point to a very high point. So their tendency to vomit is very common. So rolling them onto their left side is going to be one of your main concerns after administering glucagon IM. FYI. So you can do this until the patient regains consciousness. Of course, once they gain consciousness, then switch back to that oral supplement. So then, of course, our goal is to get their glucose above 70 on their fingers. Okay. These are the references from where all of this came from in your ATI book, pages 309 to 315, and your diabetes chapter, which is chapter 39. If you have any questions, I'll be available on the discussion board, and you can always email me privately if you need to for any private discussions. Have a great evening.